Thank you, Kia. Appreciate it. No pressure. Good afternoon, everyone. No, that was not everybody. Good afternoon. Thank you. I need some energy. How's everyone doing? All right, thank you. So today, as Kia said, today's panel is Health Inequities from Antitrust to Neglect, Returning Ownership and Quality Healthcare to Minority Communities. I am in very good company today with this panel, super knowledgeable, and they're going to really add a wealth of depth to this conversation today. I'm going to briefly just introduce everyone, but in the spirit of time, please reference your program, which will have everyone's full bio. So to my right, that is my right? That's to my right. We're going to be starting with Kevin Kimball, who is CEO of Financial Services Innovation Coalition, an economic empowerment platform where he bridges the gap between government, community, and financial wellness. Then we have Mrs. Pamela Warner, CEO of Good Healthcare Matters, bringing together education, community, and healthcare advocacy. To my left, we have Tamiko Stanley, Managing Partner, Elite Executive Strategies, specializing in healthcare policy reform and legislative strategy. And then last but not least, we have Greg Baker, CEO of Affirmed RX, leading efforts to reform pharmacy benefit managers and make prescription drugs more affordable. Super important. All right, so before we get started, I think it's always important to lay the foundation and the groundwork background of what we're going to be talking about and why this conversation is so crucial, especially in today's climate. So healthcare is more than access to treatment. So like many industries, it's about who owns the facilities, who makes the decisions, and who benefits from those systems. We know that healthcare disparities are not accidental in the least, okay? Whether it's from corporate monopolies, restricted access to affordable medication, long travel times, delay in appointment times, and God forbid if you need a specialist. So these are things and systematic barriers that unfortunately only affect communities, Black and brown communities most often, forcing families to have to choose between their healthcare and financial stability. The crazy thing is we have programs that are designed to alleviate these problems, yet they have failed to uphold their end of the bargain on multiple levels. So for instance, we have things like the 340B drug pricing program, which was created to provide discounted medication. So these are where pharmaceutical companies, they partner with like Medicaid entities, and they're supposed to sell you discounted medication, typically at a 25 to 50% discount, sometimes even more. And those savings typically should go into underserved communities, mental health programs, addiction programs, transportation services. The bucket is endless, but it never goes there, okay? Instead, because of minimum oversight, usually large hospitals end up absorbing those savings because you end up getting charged the same rate, and they end up pocketing it, and it doesn't go anywhere to the places that need it the most. Next, we have pharmacy benefit managers, which are the middlemen that are meant to negotiate those lower price costs, and they have become one of the most powerful forces behind inflated medication prices. And instead of driving the cost down, PBMs typically funnel the rebates and discounts back to those major corporations that we were talking about. So today's conversation is extremely important, especially in today's climate. So with that being said, I'm going to start with you, Greg, with the questions, okay? Now, some people, maybe most, could argue that Big Pharma is probably one of the most corrupt industries around, okay? And any entity that's dealing with it. Because if we have life-saving medication that we've studied, that we've proven, and that is supposed to help people, but because they don't have enough money to pay for it, and you tell them, hey, I don't know what to tell you, and then people die, that's criminal. But for you, I really enjoy learning about your company, Affirmed RX, because it's leading the efforts to make medication more affordable and accessible. So can you explain how PBMs have traditionally contributed to the inflation and prescription prices that have led to declining access in minority communities, and how you and your company, Affirmed RX, have worked to implement a public benefit model that creates more equitable and affordable healthcare system?
Yeah.
Sorry. That is the pharmacy benefit managers. So it's just the acronym for them.
Yeah. And Thank you for that. That's perfect. Because really, PBM, just to make sure we are talking all the same thing, because most people don't know what a PBM is, and frankly, that's by design. They don't want you to know who they are, because the more they can obscure and be in the shadows, the more profit they can make. We always joke that the PBM's mantra is in chaos, there is profit, and those guys make a lot of profit. So if you basically just think about anybody, anytime you walk into a pharmacy, a Walgreens, a CVS, and you give them, the insurance card, for lack of a better term, the person on the back end who makes all the rules associated with that card is a PBM. So they decide what pharmacy you go to, what drugs you can buy, how much those drugs cost. They are the epitome of a middleman. They add zero value to the system when it comes down to it. But to Jessica's question, I think maybe three important things matter. And that was like a question that's probably got a 3-hour response. And I know if I go past 3 minutes, I'm going to be in trouble. So we're going to really try to consolidate this because she runs a tight ship.
Thank you.
But one, first off, most healthcare companies are for-profit companies. So I think we spend a lot of time saying healthcare is broken, but it's actually not. It's working perfectly as designed because it's designed to drive profit back to shareholders. So we should not be surprised when for-profit companies are trying to make profit. And unfortunately, that's exactly where we are in America. So taking her answer in reverse about us, when we looked at all of the bad things that PBMs do, and it's mostly driven by profit motivation, we created a PBM that's a public benefit corporation. So my job as an officer of the company to board members, not to maximize shareholder value, my job is to do the most good for the most people. So it just fundamentally changes every decision that we would make as a PBM compared to the other organizations that are in this industry. Two, I agree. Pharma, so the guys that make the drugs and price the drugs, they're not innocent, and we will never defend pharma. But we also say that probably 80% of the drug affordability problem that exists in America is because of bad PBM tactics and not because of pharma tactics. And I think the best way to explain this is here. I'll just, I always lead things. Okay, well, let's just call these our two things, right? So there's a lot of manufacturers, and they make similar type drugs. You guys might have heard of Humira. It's like a $200 billion drug, right? #1 drug in the world. So Humira, is made by AbbVie, the manufacturer. They've got a competitive product from a different manufacturer called Enbrel. So these two drugs basically do the exact same thing. And while you've got multiple manufacturers making it, you've got this PBM that sits in the middle. And right now there's just 3 PBMs that control access to 225 million lives. So because those PBMs, they get to decide what drugs are covered. So both of these manufacturers know if they don't get on the list of covered drugs for that PBM, they sell no drug, right? So they don't get to sell any of their drug because the PBM says, I'm going to cover Humira or I'm going to cover Enbrel, and I'm not going to cover both. So if I was the CEO of one of these companies, which we've seen this happen over and over again, a lot of times they want to bring out their drug at a lower price point because they know the higher the price point, the less people are going to be able to afford it, and frankly, the less drug they're going to sell. So pharma is not innately motivated to drive up cost because every study out there around adherence shows that when costs go up, adherence goes down, and pharma sells less of their drugs. So they don't want to do this. But to Jessica's other point around rebates, these guys, as they're pricing their drugs, know they've got to get this back-end money back to the PBMs. So Humira being the #1 drug in the world, $200 billion in sales last year, they price their drug at about $10,000 a month, 10 grand a month. And then the PBM sells their drug at 10 grand a month and goes to AbbVie and says, I need $5,000. So AbbVie gives them $5,000 then, PBM sits there, they'll funnel like $4,000 back out to an employer and say, hey, I use my size and scale. It's a $10,000 drug, this bad pharma guys, but I got you $4 grand. You're welcome. I'm great. Oh, but by the way, I'm not going to show you that I also pocketed $1,000 for myself. So they are always incented to drive up the cost. And that's why costs are high. And so it's not always pharma's fault because they know if they don't have a high price point to give a high rebate, they're not going to get on formulary and they'll sell nothing.
Okay, so you said something most good for most people. So rising medication costs aren't just an issue of affordability, they're definitely life or death for many people. And I read somewhere that there's more than 800 counties across the U.S. that lack pharmacies that dispense life-saving medicine like insulin. So that means that even if a patient can afford it, they can't get to it.
Right.
It's like, what option do you have there? So how can public benefit PBM models help address this challenge and improve insulin access in underserved communities?
Yeah, so thank you. Great question. And again, so the PBM sits in the middle. They make all the rules as we just talked about. Well, the other thing they do is they sign contracts with state Medicaid programs, Medicare. So all federal programs have one of those bad PBMs on the back end. And all employers do too. So, and the employer and the government is the ultimate payer of this service, right? So what happens is, person goes in to try to get an insulin prescription, if there's even a pharmacy there, which we'll talk about why those pharmacies are disappearing in a second. And the PBM says, for this insulin bottle, I'm gonna give the pharmacy $10. And they wanna pay that pharmacy as little as possible. Because, so they've got to contract the PBM with this pharmacy, say, okay, person comes in for insulin, pharmacy, I'm gonna pay you $10. So the PBM is out $10. Well, then they go to the federal government or the employer and they say, hey, you owe me $15 for this insulin product I just put out. The employer or the federal government has no idea what the pharmacy was paid. The pharmacy has no idea what the ultimate person was charged, again, because the PBM sits in the middle and hides everything. So that's called spread pricing, which is a very common term within the pharmacy space. And PBM should not be allowed to spread price. So again, from our standpoint as a public benefit corporation, we have no data to hide. We put all of our data out there. And we say if we charge the pharmacy $10, I should then charge the ultimate payer, the federal government or the employer, $10. There should be no spread. So from our standpoint, we're not trying to drive down costs to the pharmacy so that we can make more money and profit in the middle, and that's why pharmacies get paid so little. So these PBMs continue to try to push that $10 next year to $9.75, next year to $9.50. So every year they're trying to negotiate these pharmacies to pay them less. And now we're at a real critical point where pharmacies are closing. And independent pharmacies are closing at a pretty alarming rate, which is driving these pharmacy deserts in a lot of different communities. So again, it is this PBM concept that is driving poor financials for community pharmacy. And when you look at Walgreens closing thousands of stores, CVS is closing thousands of stores. When those big guys can't compete with the PBM to get paid a fair rate to keep their pharmacies open, independents have no chance. So it's really sad.
I'm going to ask you one last quick question, okay? So PBM's a big part of the puzzle. I know you're working on a utility model for healthcare that addresses taxes. Can you talk quickly about that one and what legislative steps or oversight protocols are needed to regulate PBM practices?
I think, yeah, we've got a lot of things that we can think about, but I think to take a step back, you've got a for-profit company, bad. Public benefit corporation, which we are, is better, but then there's also this concept of a public utility. And we think there's probably a world where healthcare needs to move into this public utility way, right? Because healthcare is a basic essential that all Americans should have access to. Just like electricity, just like running water. And we as a society have said that we think these things, everybody should get the same access at the same price for all of these services, right? And then in healthcare, all of that falls apart. But these utilities are run by boards that say, hey, you as a company, the utility, you can't make an unfair profit and you have to share all your data. And that's why utilities are better, right? Like we could still debate good, bad on the utility concept, but it's significantly better than anything we've got from a healthcare structure. So we continue to tell federal policymakers there's no way to legislate our way out of the pharmacy benefit mess that we're in. There's none. But the best thing you can do is allow everybody to have their data and create benchmarks to have people know what they're paying, right? Because you go to the pharmacy counter, you have no idea what your drug costs. You have no idea then what was actually charged for it. So capitalism falls apart because there's no competition, because there's no data. So if we know what a drug should cost and we can compare that around what we were charged, and we're doing it in a way where everybody gets the data and can see these things, that alone would make this industry significantly better. So they can't hide in the shadows anymore and obscure, because that's why they profit so much, is because we allow that to happen.
Thank you, Greg. Those was wonderful answers, by the way. All right, we're going to shift gears to my right side. All right. We talked about pharmacy deserts. Now it's time to talk a little bit about legislation. All right, so we're going to go to Kevin. Kevin, your work has really been dedicated to addressing these structural inequities, especially through a drafted bill, Access to Reliable Community Healthcare Act, a bill designed to improve healthcare equity by promoting minority healthcare ownership, preventing anti-competitive practices, and ensuring more funding is directed towards those underserved communities. So what are some of the biggest barriers minority-led facilities face gaining ownership in the first place, their expansion opportunities, and how can legislation protect those minority-owned hospitals and clinics from aggressive buyouts and venture capital takeovers?
Okay, that's a long question.
It is, but I know you got it.
So first of all, I want to say I'm substituting for Wendy Muhammad, who's the head of our healthcare task force. She had a death in the family, so she couldn't be here. So we wanted to still have this part of the conversation. So Wendy does a much better job at this than I do, but I'll run through it. Basically, tying into what Greg said earlier, we know that health deserts are expansive in America, and because of the private equity and venture capital funding, because they're for-profit companies that are dedicated to their shareholders, the way they operate is very aggressive. It's like any other business. They want to merge, they want to close down facilities that don't make as much money, and so what happens is in a lot of communities, you end up with the black hospitals, for lack of a better word, being closed in deference to the bigger white institutions like the University of Georgia Health Center or the University of Maryland Health Center. Like we know, for instance, in PG County, there are two black-owned facilities, one a radiology center and the other a cardiovascular center, that are being run out of business by the University of Maryland so they can get their customers, so they can get access to their 340B money, all their Medicaid money. They want that. They want the customer base. So we worked on a piece of legislation, and our antitrust lawyer, I don't think Kristen's here yet, but you'll hear from our antitrust lawyer later today or tomorrow, about the ability to change the competition rules so that even though something may not be antitrust level of a threshold, can still be anti-competitive, and we can change the rules or make it so that these guys can fight back effectively. Because we met with the Department of Justice's Antitrust Division last year about this, and they said most of the smaller companies, the $20, $30, $40 million healthcare companies, weren't big enough for the DOJ to try to save. So we are looking, so the bill we have addresses the antitrust, the anti-competitive nature of things, and also addresses the funding. So funding for healthcare, as you know, African Americans get less than 1% of venture capital money. So if you have to have venture capital money to start a health facility, you can't do it. For instance, I don't know, in Alabama, in Tuskegee, Alabama, if you live in Tuskegee, you're 30 miles away from the closest hospital. They've been trying to build a hospital for several years. They're trying to get financing, but it's virtually impossible because they are African American to get the funding that they need to actually start the hospital. So the bill that we're working on has funding mechanisms, taking money from 340B or some of the tax provisions that Trump is going to try to extend, like opportunity zones and other places, to require that venture capitalists put money into minority-owned health facilities.
Thank you. All right, so you mentioned 340B, so that's great. It goes into this next one. How do 340B savings, how can they be directed to minority-owned healthcare facilities, and what role does financial support play in closing these gaps?
Financial is almost everything, right? I mean, it costs a lot of money to have a hospital. And, patients are customers for all intents and purposes, and most healthcare is paid for by somebody else. Most of us don't pay for our own healthcare, either through our insurance companies, or we have Medicaid or Medicare, or some other institution pays our healthcare. So we are just numbers on a page. 340B is one of those programs where patients get discounted drugs, and the hospitals or the service providers who use that have excess money. So the drug costs $100, they get it for $10, so they get to pocket the $90. They're supposed to give the drug to the patient for $10, but often they charge the patient more than that. So there's a big slush fund of money, and we're thinking that 20 to 30% of that money should be dedicated to making sure that there are facilities across the spectrum so that we don't have 800 pharmacy deserts or 800 insulin deserts in America, and that people in Tuskegee don't have to drive an hour to get to the hospital.
That money allocation is a big thing. So last question, Kevin. People see these bills, sometimes they don't go anywhere, and they think that they're difficult to implement when they're really not. You just need oversight, you need, a very structured plan. So what action can policymakers take to ensure minority healthcare providers are protected from discriminatory regulations, lawsuits, and unfair treatment from those larger entities?
Well, two things. One, the providers need to organize themselves, which they are not organized. Like, there are trade associations, healthcare groups all over the country have different trade associations to fight for their rights. Secondly, they actually need to develop policies. Like, one of the reasons where this whole summit is geared towards advocating for policy change is that we don't do that. Right? There's no one in this room, I can tell you, well, most people in this room are separated, but in our communities, the doctors don't fight for themselves. We know 20 doctors who have been running a business around the country. They are not organized. They're scrambling by. We are not set up to agitate and to get our members of Congress, because this all starts. There are, like I said, there are 120 minority members of Congress. There's no reason we don't have a bill with 120 signatures to deal with this issue. Right? And so but that's on us. Everyone in this room is responsible for that. I mean, you haven't, I know that Josephine's very close to several of her members of Congress. It's coming upon her to make sure they get on the bill to do this, right? All of you guys, Martin and Malika over there, they know the New Jersey. Everyone in this room has got to take it upon themselves. We've got the apostle in the back. She's got her Congressman for Richmond. All of y'all need to make sure that these members are doing what's necessary to push forward on our agenda.
Perfect. So theme for today, organize and implement. All right. So going to switch back to my left over here, Ms. Tamiko. Ownership and investment, super important. But there's still gaps that directly affect patient outcomes outside of this. So for instance, clinical trials. There is not enough participation from African American communities. And it's so important, especially when there's things that affect us more, like cardiovascular disease, maybe medicine, your heart, your hypertension medicine, your ACE inhibitors give you African American swelling more. Or say sickle cell. Sickle cell, African Americans account for 90% of sickle cell cases. So it is shown that we need to get into these trials. So when we're talking about that and cultural competency, that's what I really want to focus on with you today specifically. So you've worked extensively in DEI and strategy development, and we know right now they're trying to take DEI from everything. So what role does DEI play in improving healthcare access and outcomes for minority communities, and how can healthcare organizations integrate that effectively into their operations, creating lasting change?
Absolutely, yes. DEI is definitely under attack right now, and that is certainly by design, right? A lot of what has been discussed today so far is also bringing us back to the fact that we have to acknowledge that these systems that are in place did not create themselves. These systems that disproportionately impact communities of color for a legacy of time, since the beginning of inception, since they've been created, right? They did not create themselves. These systems were created, designed, architecture created, and managed, continue to be managed by human beings, right? All of these individuals that are throughout the infrastructure of healthcare are human beings. And they are human beings working within the confines of their own perception. And so that's why we have this continuous systemic inequity. The impact is inequity. The impact is racist outcomes and disproportionality. And that's why you have, quite frankly, the outcomes that we have. That's why I can go in to give birth and be 3 times more likely not to walk out of that hospital as any of my non-diverse counterparts. That inequity transcends every other dimension of diversity. So that means it doesn't matter how wealthy I am. It doesn't matter how educated I may be. It doesn't even matter how well connected I may be and how I may sing in the choir with the CEO of the hospital. Only because I am an African American woman and I present at that facility as an African American woman, I am less likely to survive childbirth than a non-African American woman. And that is how you can have a Beyonce and a Serena Williams almost die giving birth, where that will never be the experience of their non-diverse counterparts. So that forces us to really look at the root cause of some of this, and the root cause of some of this is based on the fact that the people in places of healthcare, whether it's in pharma, whether it is in direct patient care, whether it is in healthcare management, are not fully equipped with the ability to mitigate the impact of bias. And bias is present and is going to be present forever as long as we are human beings with a brain. And quite frankly, it's going to transcend human beings because we are now feeding AI, and that's a whole nother discussion. You can join me next week on Thursday on YouTube if you want to talk about that. Because the truth of the matter is, until we get real and start to legislate, and I hate to say this because everyone likes to push back, until we legislate human behavior and make that policy and require individuals to be in tune with what racism looks like, because a lot of people who are racist unfortunately have no clue that they are racist. We're in a climate right now where it's becoming a little bit more evident, but even then, it is still people who are very well-intentioned. Racist people do not wake up in the morning and say, I can't wait to offend as many people as I possibly can. That's not how it works, right? They are on, for the most part, on a journey for impact and usually with intentions to do good. But they lack the ability, they lack the training, and they lack the awareness. And that's where I think there's opportunity for us to talk about legislation is at the beginning. How do we legislate bias? How do we make sure that we are equipping all of these people who have human lives in their hand to understand what unconscious bias looks like and how to mitigate its effects?
So you hit the nail on the head and you mentioned training. So from an operation on an HR perspective, can you quickly tell me how can facilities attract, train, and retain more minority healthcare professionals? And how does that leadership accountability look like to improve that access?
Okay, I'm gonna try to whip through as fast as I
I
possibly
know, we
can.
got back there.
Oh, sorry about that. I've never been accused of being quiet though, but I'm sorry about that. So I would say, so first of all, holding institutions accountable, right? So tying that to their incentive programs, tying that to, quite frankly, anything that is revenue or profit-based. So there should no longer be access to incentives and cash flow that is from our taxpayer dollars when an institution has not required the eradication of systemic and structural racism within their systems, within their policies, their procedures, and within their employee behaviors. Also, with Maryland, really right now, as large as the United States is, Maryland being the only state that requires physicians and medical providers to complete unconscious bias training before allowing them to renew their annual licenses, that's an issue. That should be a federal requirement. Every person who has human life in their hands as their job should be required to recognize and understand what their personal views look like in terms of impact and health outcomes. And that should be legislated at the federal level, and it should not be something that lives at the state level. I'm proud to be a Marylander now because we do have that, but that should not live at the state level. It needs to be higher. And organizations need to infuse that training in order for people to get things like promotions, bonuses, raises. It should be tied to the bottom line.
So quickly, you touched on it. You said little proposals in there. So how can we incorporate those policies to expand on that, the ownership and the infrastructure inside and out?
So the power is with the people. I know that's so cliche, and it sounds like it's an oversimplified answer, but quite frankly, that's the truth. We all have the ability and the power to force this change. We are the patients. We are the providers of the income, the profit. We fuel and fund healthcare as patients and end users. And so it's really up to us to require that of all of our service providers. What does that look like? That looks like starting at the grassroots level with just your local care provider and asking them, quite frankly, what do you do for cultural competency, and how does your organization infuse cultural humility so that you can see me in all of the unique dynamics that I present, so that you can treat me accordingly and don't treat me with a blanketed approach towards care. What are you doing? And then there's a broad way for us to approach that from a legislative standpoint and hold the people that we put in office accountable for speaking on our behalf and making sure that's something that is not just written in as a intention or, this has been around a lot, executive order. No, it's infused, and someone is lobbying for true legislation, and it is infused throughout the fabric of our country, because it has to be something that we hold people accountable to, or we're going to continue to see the inequities that we see, which is more comorbidities, more mortality for communities of color.
Thank you. Those wonderful answers, Tamiko. So, going over to you, Ms. Pamela, and last but not least, we've talked about legislation, we've talked about pharmacy, we've talked about infrastructure and DI, but we can't forget about the most important piece, the people and the community. Patients, connecting with patients doesn't happen in a vacuum. You need to build a level of trust and have proactive engagement. Pamela, there's been a long-standing distrust of healthcare institutions, and that distrust is valid, especially in African American communities. What strategies have you seen succeed in ensuring marginalized communities feel empowered to seek care and participate in their own healthcare journey in the first place?
Yes, ma'am. So you are correct. A lot of people, they're scared to go to the doctor, not scared to just what they think they're going to hear. So my role is to go out in the community, educate, encourage, to be proactive about your own health, first of all, because it's a team effort between you and your doctor. Educate on the services that are available, ACA, Medicaid, Medicare, just to educate the community on that, and to encourage the clients or patients to interview your doctor. Old people, you say, get a second opinion, but be proactive in your own care. You know your body more than anybody else. So that's the first step, is being in tune with yourself and being able to just know it's time to see someone. But unfortunately, right now, the doctors are so booked. They'll call me and say, Pam, I tried to get an appointment. They say they can't see me for a year almost. I don't know if some of you all have experienced that. So that's creating a level of mistrust. And especially the doctors are in there, 10 minutes, but at the same time, we got to give the doctors credit. They're overworked and some of them are doing their best. But what I've seen to be most successful with trying to make sure that people be proactive first, and then also the doctors giving more of a level of comfort to the patients and not treating them like an assembly line. So what do we do that? That's back to what she said, making people accountable.
Mm-hmm. Yeah.
And so
I think that is so true, because working in so many different hospitals, people see it from both sides, and I see it like the system is just completely overworked.
It is.
I mean, to doctors, nurses' credit, it's like it's hard when you got 50 patients a day. Like, there's so many times you got to be in and out.
Right.
So that involves a level of proactiveness and advocacy on the patient's part as well, to come in there and know exactly what you're asking, to already know exactly what you need to have done and educate yourself. So when we're talking about education, we also need to talk about the lack of resources and awareness. What strategies can healthcare systems implement to proactively educate those underserved communities and people maybe on a lower income levels, maybe who don't have a certain education to be able to interpret those things?
Right. So a lot of some of the clinics we work with in the hospitals, they have health fairs. They have where you're coming in to see them during, more proactive times, come learn about insulin, learn about your diabetes, how can you reverse diabetes. So those types of situations and fairs we found to be successful that clinics and doctors can implement, to help increase that engagement, right.
So last question. I think if you are in minority communities, school and church are usually pillars in our communities. So, but I feel like those things are kind of we're stepping away from them. They're not as involved anymore for change that they used to be. You don't see them out there pushing for these things. So what role can public schools, churches, and local organizations play in strengthening healthcare education and advocacy efforts in those underserved communities? Because we need actionable items here.
Absolutely. So really taking it to the streets, unfortunately, because unfortunately a lot of these programs that we're talking about, the people that need to hear about them don't come. So we're talking about grassroots efforts, the mobile clinics, the similar to what the census does, although we have HIPAA compliance that we have to do right now. But basically doing grassroots efforts is what I see as a great way to get that in the community, because and mental health, first of all. Because when I'm at the food banks, when I'm at the Salvation Army, doing those types of setups, just trying to educate, trying to tell people what's available, it's like they don't want it, it's like they don't hear it. But I think if we can reach people, it starts here, everything starts in the mind. And if we start, what's that old saying, if you start with your head, the rest will follow. So starting with mental health resources, I think, to have people want to be engaged, to have, if you're worried about just where you're going to live, sometimes people, it's just only so much time in a day. And so many times, unfortunately, your health care becomes one of the last things until it's too late sometimes.
That is true. We got a lot of problems in our buckets, and it's like, which one we got to focus on first? So all of those answers were beautiful, and I want to ask one last question to each one of you quickly, and we'll roll down. We'll start with Kevin. If policymakers and change agents, all of you guys in the room, were to leave today with one actionable step to advance healthcare equity, what would you specifically want them to prioritize and know?
I think the number one thing is to be on the lookout for us to reach out on legislation and get you to co-sign letters to your members of Congress. Take time to come to D.C. and visit. We're having this meeting here, and I know some of this stuff is kind of dense, but everything we're talking about here is dollars out of your pocket. Every panel you will see today is whether you'll be able to make it in life or not, whether you'll be able to start a business. The next panel is about government contracting. And I think DeMarc said people should donate. I think that's they should show up, and they should organize their communities. And don't be afraid to engage. Sometimes it's boring. Not all of us love policy or politics, but every word that gets uttered in Congress is dollars, is money. It's your ability to have a house, to have appraisals. Everything is policy, and so. Being aware is the number one thing, and showing up is the second thing. So that's my answer.
Ms. Pamela?
I guess my number one thing would be funding for those, believe it or not, even though we have Medicare, Medicaid, and ACA, there's still some people who fall right in the middle who don't qualify for either.
Yeah.
It's amazing. So those people are the ones that I have a special soft spot for. So additional funding for those individuals who don't qualify for the current programs.
That's very important point. Thank you for making that point. There's a lot of people that are left behind, unfortunately. Tamika?
I would say investment in diverse youth. Really encouraging our children and young adults to explore healthcare, think about becoming a physician, think about being a healthcare CEO, so that they can lend their experience and their perspective and how they have seen healthcare impact their families and their personal stories to the business. I think the human element of healthcare has been muted and it's continuing to be reduced and eliminated out of the business of healthcare, and we have to get back to the human element of healthcare.
Absolutely. Okay.
And I guess just to end, obviously, but following on what Kevin said, I'm always impressed when I talk with Kevin because he knows a lot about healthcare, and he's really never worked in healthcare, right? He's a lawyer, and he's a nice one at that, so I appreciate that. But like, so I live in healthcare, so I can come up here and talk about PBM, but there's so many other things that are on this agenda, the next couple of days that I don't know anything about. And I think it's important to remember, especially if you show up and especially if you organize, and then when you start talking to any either state or local policymaker, they're in the same boat, right? Like, I know my little area really, really well, but they've got to touch everything. And I think too often we see people try to get this really deep, comprehensive message to somebody who knows this much. So I think the words that you use and the messaging is always going to be incredibly important to have that impact. Because I think too often we make the effort to show up, we make the effort to get out there and talk to policymakers, but then we still lose because the message isn't what it needs to be to get that impact. So to really keep it simple, but do it in a way where they leave thinking, oh my gosh, I'll remember that, and that was important to me, and it's something I want to do something about now. So simple message to me that is got that emotional tie is the best.
Absolutely. Thank you, Greg. That was a great way to close that out. So I know we talked about a lot today in minimum time. I wish we had another hour or two to cover these important information. But everything that we talked about is interconnected, and we need to remember that it's people over profit. And the only way to get this done is to have good legislation and policies that are implemented. And we need to be a part of those rooms that do it. Or we're going to continue for minority communities to continue to be left behind. So I hope today with this conversation, it kind of sparked something within you guys and giving you some actionable items that you can go forth with. I want to open up the floor in the last 8 minutes or so that we have. If anyone has any questions for our panelists. Yes, ma'am. Yes, ma'am. You.
Yes, I do have questions and I have concerns, especially living here in the DMV. We have a lot of big health groups like Kaiser Permanente, Loomis, and all of them, right? And so the other thing that we have is we have a big popular group. We have a big supply of black doctors here. But I find that these big groups like Kaiser and Loomis is trying to force the independent black doctors out of business because they want them to come work for them. And if they come to work for them, then they get to control how long a doctor spends with the patient. So, of course, we are always, and I say we as African Americans, we're always the one that get the worst side of the coin, I would say. Because the other thing I find that living up here, I've seen a lot of people misdiagnosed by these companies. They're told they have gallstones, they go in to remove the gallstones, they find stage 4 pancreatic cancer, close them back up, so you got maybe 2 weeks to live. And this is not just one person. I've seen about 10 or 15 people go through this with these big companies like Loomis, Kaiser, and all them. Now, they have the equipment there to run any type of test they have to run. When I go to my doctor, I have to go to a radiology facility to get tested first. These big groups like Kaiser and Loomis and all of them have all the equipment there. But I find that they don't use this equipment when it comes down to people of color. So if you got it there, why are you not using it? That is where we need to be fighting. Those big companies like that forcing our independent doctors, trying to force them to go out of business. That is where we should be fighting them, not
Yes.
not our.
Yes.
Well, maybe this could go through our congressmen and senators too, but I'm simply sick and tired of seeing it.
Yes. Thank you, ma'am, for that comment. Next question, make sure we keep it brief because we only got about 4 or 5 more minutes.
Well, I guess for me, thank you for this very informative panel. way in, helping maintain proper health in our community? Because all the issues that we're talking about is still products of structural racism. Unfortunately, it's likely not going to go away. We should do all these things and continue to do them, but there's so many things that we can do within our community to educate ourselves. My daughter, eldest daughter, has sickle cell anemia. I go to a naturopathic doctor in New Jersey. I pay out of pocket $1,000, but she does a dry blood cell analysis about every quarter, and we'll see, she looks at her cells, and we'll see based on the structure what's missing, and will gives her supplements to help constitute her cells. And she gave us recommendations for these filters and things that to get all the toxins out of her body. And she's like up and moving, working, doing everything, complete night and day from when we were in the hospital and just pumping her full of drugs. So what I'm saying is that we don't want to forsake Western medicine, right? We want to make sure we're utilizing and we're advocating for ourselves. But I also think that the personal responsibility that we all have cannot be understated. So I'm curious as to what role that might play. We can't continue asking the same system to honor our humanity, who has proven over and over again that they refuse to do it.
So I'm going to kick this off to whomever want to answer, but I will quickly say I'm a big fan of holistic medicine. However, the problem starts with most of it's never covered. So if you can't go do acupuncture, if you can't do all of these other type of modalities, then where does someone start? Many people don't even realize these things can help them in the first place because they're not covered and they're too expensive. So if anyone wants to quickly, Tamiko, jump on that one, and then we'll get one more question.
I'll jump in for a couple of reasons. Number one, my sister has sickle cell, and her quality of life is 0. At this point, she cannot even lead a full life. She can't work a job. She can't really stay out of a hospital for more than 2 weeks out of the month. And I worked at Luminous Health for 9 years as the Chief Justice, Equity, Diversity, and Inclusion Executive. And one of the things about the holistic care is that when we speak, and we speak with our partnership and dollars, big organizations listen. So organizations like Luminous Health have partnered with Holistic Remedies, and now so if you go to physical therapy, you will see that there are Reiki and acupuncture and all of these other elements that are included, but the ones that are included are the ones in which they can be successful at partnering for coverage. And so while we're having all of these other conversations about the inequity and how it impacts us on a very individual basis, it still brings us back to this policy issue, because the barrier is oftentimes the legislation and the confines of the regulations that govern the space. And that is where our greatest, there's tons of opportunity everywhere, but our greatest opportunity for impact is being educated about and able to inform and influence the legislative policies that governs the business that is about our bodies and our life. And I think for us as a community to try our best to make that a priority, and it quite frankly should be a part of the educational curriculum within our schools. Again, a whole nother conversation. But we have to prioritize understanding the legislative arm because it drives all of the conversations we're having about healthcare.
Yeah, thank you. Last question, this gentleman, you had your hand up.
All right, so thank you to all of you that are here. Ms. Lewis, I know kind of it's maybe closer to you here because I know you have a background as an MDS and an RS. So one of the questions that I would have for you is about what are the things that we're doing to help with reforming policies that are affecting the shrinking of rural hospitals in underprivileged service areas. I have a background in public health, so I usually look at social determinants of health. So you all kind of all come across that. But what we do seem to notice is that there are these deserts that you spoke about that are being created, specifically like here in the DC area. We know that, and I moved here 8 years ago, working with United Medical Center is now closing on 15th May. And as a result, they do have a hospital that's replacing that. But over the years that I've been here, you tend to see these other institutions like Providence Health and so forth, that are just kind of disappearing. And as a result, it's what you all talked about. They've been either eaten up by a larger conglomerate that has come back in and taken them. But then we still have populations that are growing. As a result, we have things that are out of control, like diabetes. We have issues that are all related to these community issues, is what I want to call them. And as a result of hospitals closing, then we don't have the access that's there. So I would kind of say, what I'm looking for is to see, guys, where are we going to perform like that? Because that is very important. Because again, like while I live in DC, I know that definitely further out west, Texas, places like that, they're closing down centers left and right.
Yeah.
So where do the hospitals have the ability for us to be able to recruit and come back in? And specifically, that's why I talk about DC. Well, United Medical Center was one of the last few not-for-profit hospitals. So when we go back into the conversation is, are we letting big corporations run our healthcare groups to that particular level?
Who would like to address that? Keegan?
I was going to say, I'll throw it to Greg too, but part of this is the structure is wrong. I mean, that's why we're talking about public, you have to change the structures, because as long as the profit motive is there, I mean, venture cap VCs and Ps require like 20% returns on their money, right? So that you can only have so many facilities if you're going to return that kind of money dealing with patients, right? So a lot of it is just the structure is bad, and we've got to so to your point, in this tax bill, maybe they should, when they try to cut money from Medicaid and Medicare, we should ask them to limit the amount of profit VEs or hospitals can pay, or what their financing can look like to get a new hospital started, because that's the kind of thing that will address that.
Yeah.
All right, well, like Greg said, I run a tight ship, and we're exactly at 50 minutes. So I would love to take some more questions. I know our panelists would welcome any questions after this. I would like to thank our panelists, our organizers, and even you guys for showing up today and being a part of some of these vital conversations. So yeah, that is it for today. Thank you.